This is good because you don't need to see my ugly face, so just see the waveforms.
Okay.
Okay, so kind of an abbreviated run through of graphics, what we'll do here, and we're going to start really, and this will be kind of a mingling of mode lecture with graphics so that people understand what we're dealing with when we talk about different modes and different graphics. So right now we have volume control going. So I know that a lot of hospitals don't use old-fashioned assist control volume anymore, as we used to call it, but just as a premise to the way the mode works and the way we can get into talking about graphics. But in volume control, what we're asking the ventilator to do is deliver a certain amount of flow for a certain period of time, because flow over time is the volume that we want to deliver. So we're delivering 500 cc's now. So if we look at this graphic here, this flow, we're delivering this flow going up here, that's 30 liters per minute, and we're asking the ventilator to deliver a constant flow for 30 liters for 1 second of 30 liters per minute. So if we do the mathematics associated with this, 30 liters per minute times 1 second, the area underneath this curve is the amount of volume that we're delivering. So if you remember from your geometry days and figuring out what the area of a square is, that's length times width. So a square table of 2 times 2 feet by 2 feet is 4 square feet. That's the surface area. So a rectangle, if this were inches and feet, or inches, we'd say, all right, if this is 2 inches and this is 6 inches, we'd say the area of this curve is 12 square inches. But because we're talking about volume and flow, if we measure this at 30 liters per minute for 1 second, we can say that the area underneath this curve is 500 cc's. That's what it is. If we deliver more flow for the same period of time, the box gets bigger. So the area gets bigger, so consequently we're delivering more volume. So the point of this is that the flow waveform, if you could have only one waveform on any ventilator, it would be, as far as I'm concerned, the flow waveform. Because we can tell a lot, we can tell leaks, we can tell a lot of things from the flow waveform in terms of how much volume is being delivered, whether we have leaks or not. Now, in addition to this, this is the inspiratory side of the graphic, but here's the expiratory side. So when the patient exhales, this is his peak expiratory flow, and his flow comes back to baseline, and this area in here should be the same as the area in here. Because if he gets 500 cc's, he should be exhaling 500 cc's. But we can't do the length times width formula for a triangle. That's a little bit harder to do. I think the formula of area of a triangle is what, 1/2 base times height or something like that. So it's a little more complicated to do, but point once again is the area of this triangle is the same as the area of this square, because 500 goes in and 500 comes out. So if we keep that in mind, that'll help us in terms of interpreting graphics later. So in volume control, to talk about the mode, what we're asking the ventilator to do is this. We're asking it to deliver 30 liters per minute for 1 second. And when it does that, it creates a certain amount of pressure in the lung. So as flow goes in, the pressure rises to some peak pressure that is created as a result of delivering this much flow or this much volume, I should say. So our peak airway pressure is a function of how much flow and volume we're delivering down here. So if I go back to the ventilator now, and I make a setting change, but before I do that, notice here that the amount of flow that I'm delivering is 30 liters per minute, and I'm delivering it for 1 second. So 30 liters per minute times 1 second equals 500 cc's. If I said, all right, I want to deliver the same volume in half the time, what do you think is going to happen to this number? It's going to go up. And what will this number be if I cut this in half? 60. So if I turn this down to 1/2 a second, in order to deliver the same volume in half the time, the flow rate has to be double, right? So that being the case, and before I do that, let me increase my upper pressure limit. So I go here, and I go here, set this at 0.5. So now notice the geometry of the flow waveform. So the flow waveform is much shorter in time, but it's taller in flow, but the area of this is no different than the area of the previous flow waveform that you saw. It's just that we're spending less time with more flow. And so the area of this curve still is 500 cc's. And the area of this triangle is 500 cc's as well. Now notice what happened when I did that. The peak airway pressure went up. So why did the peak airway pressure go up? Well, what's happening is that I'm trying to deliver the same amount of flow through the same size airway, and although the compliance of the lung didn't change, I mean, you might on initial blush say, oh, wait a minute, his peak airway pressure goes up, he's worse off. If this patient's lung didn't change at all when I made the change, but what I did was I'm trying to get the same volume through this small airway in less time. So as a result, I'm creating more frictional resistance, which is causing the peak airway pressure to go up. Now, how do I know that? Well, if I do an inspiratory hold and look at the plateau, my plateau pressure is there, right? Now, I don't have it set up here to see, but let me go here, and now there's my plateau pressure. So I'll do it again when I do my plateau pressure. My plateau pressure reads 26. So if I go back to my I time and I change my I time back to 1 second, but still want to deliver the same volume, my peak airway pressure goes from 53 to 35. So did the lung change? No, the lung didn't change. What I'm doing is delivering the same volume, but I'm pushing that volume in at a lower flow rate. So what do you think happened to my plateau pressure? Did it go up, did it go down, or did it stay the same? Some people would say, well, it went down because this went down. But when we do this, we do an inspiratory hold, and the plateau pressure is essentially the same. So the plateau pressure can be a function of how fast and how much flow you're delivering, so be wary of that when you're setting up your flow rate. You want to set in volume control, and this is only in volume control, you want to set your flow to meet your patient's demand, but you don't want to set it so high that you're causing a lot of frictional resistance that can inadvertently give you a high peak airway pressure and mislead you to think that compliance is bad, right? Because when we do the inspiratory hold, this plateau pressure represents the compliance of the lung, and the difference between your peak airway pressure and your plateau represents the resistance of the airways. So what do you think would happen if this was an asthmatic patient now, and all of a sudden he went, you know, his airways became restricted? Did anything happen to the parenchyma or the alveoli of the lung? No, there's nothing in a pure asthmatic, it's just airway. So in a pure asthmatic with airway, now I'm creating, now I have a greater amount of resistance, but ultimately what I would see if I did my compliance is the plateau pressure would be the same, but what I would see would be something more like this. So I would see my peak airway pressure go up, but when I did a plateau pressure, the plateau pressure would be the same as it was, but the difference between here and here represents the amount of change that occurred as a result of the resistance of the airways. And so if we gave a treatment, then when we would notice the peak airway pressures come down, but our compliance wouldn't change because the treatment helps the airways, not necessarily the alveoli. But usually with patients that we deal with, it's always a mixed problem that we have compliance issues and resistance issues. But you can always tell the difference. A resistance issue relates to your difference in your plateau versus your peak, and a compliance is basically just your plateau. That's why we want to do serial plateau measurements on particularly ARDS patients to monitor how bad or how good the lung is getting as a result of the disease process. So when we're looking at graphics, we want to look at the area of this curve representing our tidal volume, and the amount of volume that we're delivering will produce a certain amount of pressure in the lung depending on the compliance of the lung.